I'd like to introduce again my colleague Helena McMeekin to give the next talk, which will be on medical device regulations and what it means for everybody. So, Helena, if you're ready to go, perhaps you could share your screen.
Yeah, give me a second. We are getting going with the screen share. Okay, can you see my presentation?
I can see your presentation. I just can't see you.
Can you see me now?
I can see you now.
And if I change the slides?
Yes, that's working fine.
Yeah, perfect. Okay, great. So my talk is on the medical device regulations and what it means for everybody. I will attempt to tell you what it means for everybody, but I'm not totally clear on that at the moment. Okay, so an overview of my talk is that we'll talk about the EU medical device regulations from the perspective of CE mark software. So that's obviously how Hermes are concerned with the EU MDR. Talk about it for in-house software, because I know that's a concern of lots of people, lots of our customers who use spreadsheets in particular for calculation of patient results, such as GFR, and the UK status of these regulations. Then I'll go on to talk about the Hermes side of it, so our compliance with the MDR, and a piece of work that I did to help with the Hermes compliance for the clinical evaluation report. I did that for the nuclear medicine processing applications, so we'll talk through that as well. Okay, so going straight into the EU MDR. Here it is. You can access it online at this link. If you have a spare few hours to read through it, you can do. But these are the useful bits as far as the relevance for commercial medical imaging software is concerned. So for software that will be CE marked, such as the Hermes software, we have to have a quality management system for our software. We have to do post-market surveillance. We have to have a system for risk management, for reporting of incidents and field safety corrective actions. We also have to do clinical evaluation, post-market clinical follow-up, assessment of clinical risks, and we have to employ somebody to oversee all of this who fulfills the minimum conditions of the qualification. That's for us. For in-house software, so for you, our customers in the hospital who want to use your own spreadsheets as well, or possibly your own written software, there's a kind of watered down version of that. But in Regulation 5, Article 5 of these guidelines say here that you have to have this appropriate quality management system still in place. They also say that you are only really meant to be doing in-house software if there isn't a viable alternative piece of software that is CE marked somewhere else on the market, but that obviously is not the case for GFR spreadsheets. And you have to use, you have to review the software with experience gained from clinical use and take all necessary corrective actions. So you've kind of got a similar feel, but just slightly less stringent. So the current regulatory status in the UK is a bit fuzzy. I spent a confusing few hours yesterday afternoon trying to work this out, but the EU MDR, so those regulations that we just looked at, will not apply in Great Britain because they were not enforced during the transition period when the UK left the European Union. But there will be a new GB regulatory system, and that will apply from the 30th of June 2023. So good news there is that we do have more time to prepare for that. There's not much known about this new GB regulatory system, but it will probably be based on international standards, and it will be trying to harmonize globally with other similar standards. So there's probably be quite similar to the EU MDR, to be honest. There's even rumors that it will be more stringent than the MDR, but that's not known yet. In the meantime, IPEM have published this guidance document that you can look up for in-house manufacturing. But the IPEM advice, in summary, is that it's good practice to meet with the MDR requirements, and it ought to be good preparation for this new GB system when it comes in. Okay, so moving on to how Hermes comply with the EU MDR. So obviously this is an important thing for us because our software must be CE marked before we can sell it. So we employ a quality manager. We have a quality management system, risk management system. We do post-market surveillance. The bit that you're probably most interacting with is our system for reporting of problems and corrective action. So this is support. We have to legally be able to demonstrate customer support. So all of the emails, so when you first send us an email where you found a problem perhaps in our software, all of the email chain of our response to you trying to investigate the problem, are then referring it to our QA team to investigate and then maybe issue a bug fix, and then our installation of that bug fix at your site, and then the confirmation email from the customer saying that it's fixed. All of that comprises our legal demonstration that we are doing this. This is the field safety corrective action stuff that's part of the regulation. So obviously customer support is important because we want you to be able to use our software well, and we want to fix problems, but it's actually a legal requirement to demonstrate that we are doing this. We also do ongoing clinical evaluation of the software performance, and all of this allows us to maintain our CE mark. So that means that the legal responsibility for software performance rests with us, rests with Hermes, not with you. The only bit of software that we provide where that's not the case is a macro. So if you have a macro running at your site, then that is not covered by our CE mark. And that means the legal responsibility for the software working properly rests with you, the hospital, rather than with us. Okay, so now we're going to talk about the clinical evaluation report that I spent a long time working on for hybrid view and nuclear medicine processing. So what this is a report that's required for recertification. So this is what we do to be able to maintain the CE mark on our software. So essentially, this is to do with making sure that our software is still up to date and it's still relevant, and that there's no new scientific findings or changes in the medical, scientific and technical knowledge that would mean that what we do isn't relevant anymore, maybe it's obsolete. So there could be changes in the test methods, any new scientific findings. We have to take into account experience on comparable devices as well to be able to check that we're still clinically relevant and accurate. So I performed a literature review for all of nuclear medicine processing from 2010 to 2021. So you can appreciate that took quite a long time. So what I had to do was, in the last 10 years, evaluate with respect to hybrid view and nuclear medicine processing any publications that I found in that time that were directly using hybrid view and nuclear medicine processing. So that's probably the most direct way that we can demonstrate that our software is still relevant and useful, is that it's being used effectively in a clinical context. Or if there were any publications using comparable software for the same purpose as the hybrid view and nuclear medicine processing, but not Hermes. So for example, if a different piece of software made by GE or made by Siemens or any other manufacturer used, for example, the Rutland-Patlak algorithm that we have in our software as well for background subtraction in renograms, but it was found there was a problem with it, we would need to check that problem, was that a problem with the algorithm itself? Maybe in certain circumstances that algorithm is not accurate, and therefore we'd need to reflect that in our software too. Or was it just a problem with the way they had implemented it in their own software? And also any publications detailing new methods as well with any software, which is often in-house software for the studies processed in hybrid view and nuclear medicine processing, which make sure that we're still up to date with the most recent advances in the field. And after all that, we say, are there any issues or any improvements we can make? Okay, so I'm going to give an example here for DMSA and classic DMSA. So I had to run through all of these checks for every single one of the Hermes nuclear medicine processing applications. So for renogram, for gastric emptying, for DMSA, for colonic transits, for everything. So this did take a number of months for me to complete. So I used PubMed to do the searches, and I used the advanced search builder in PubMed. So you can see here an example of the search terms that I've used, searching on the left-hand side here, searching for DMSA in the title field. That brings up 150 results. Searching for the written out full title of DMSA, and then searching DMSA in any field in these journals that I know that often we find nuclear medicine publications in. So this means DMSA could be in the abstract of nuclear medicine, of a publication in NMC. Same thing for the EGNMI, a few other publications. And then this last one is DMSA anywhere in the fields and Hermes anywhere in the fields as well. I also check through all the guidelines publications to check that we're in line with what they recommend. And the idea here is that we can demonstrate that we've done a thorough search, even if very few relevant publications are found. We have some very niche applications that are not really used so much anymore, but if I can show you I've done this, then we've done our best at trying to make sure that we're still relevant there. So having a look at the DMSA title results, I've got 6 of the returned publications for that search. So I reject many of these based only on the title. So I only review the abstract if the title sounds relevant to quantitative processing, or if it's a purely clinical study, sometimes I look at it to see if the Hermes software was used. And occasionally I recognize the authors as our customers, which is fun. So looking down this list on the right-hand side, so the eagle-eyed of you might spot we've got a clinical-looking publication here involving DMSA. But we've got Richard Peace here from Newcastle. So I was excited that this might be using Hermes, but on further inspection, it's I think a purely visual look at the DMSA rather than using the hybrid viewer quantitation. But yeah, could have been. The next one is a dose assessment, so that's not relevant here. This one also looks pretty clinical. This one's actually involving rats, so not useful in this case. This one also looks like a pretty clinical study. These don't look like our customers, but this one, semi-quantitative, all right, analysis, ultrasound, maybe not so good, but versus DMSA. So okay, maybe that's worth a look then. And so then when I choose out of 150, I'll choose a subset of them to review the abstract. And then I include it in my report, and depending on how relevant it is to the processing that we do in hybrid viewer, the quality of the evidence they present, and also if it's a new method that they've said is better than their current methods, or is it's different from what we've got currently in hybrid viewer, I will check the clinical validation they present as well for that. Okay, so here's some examples from my DMSA write-up from the clinical report. So first of all, I've found this joint guidelines publication, and I make sure that, yes, all of the recommendations for analysis and display are available in Hermes DMSA. This next one is that semi-quantitative analysis paper that we saw on the previous page. I haven't reviewed this one particularly highly because it's a visual analysis only. So they use this paper uses a scoring scale of 0 to 9 to kind of quantify their visual impression. So I didn't think that was really that useful or that relevant to the Hermes DMSA application. A really nice paper now that I found, which uses an automatic void drawing algorithm or SPECT DMSA, and it compares that to a manual segmentation. They have a new way of doing attenuation correction for SPECT DMSA that doesn't require a CT. And they compare this split function that they calculate for planar DMSA and SPECT DMSA with their new method. And they say that for ectopic kidneys in particular, where the different depths of the kidneys makes the attenuation correction quite important, they get different results between this new SPECT method and the planar method. So that was interesting, and I thought that sounded something that Hermes could usefully include and learn from. So my improvement suggestions from the Hermes QA team are to include SPECT DMSA processing, to include this new method for attenuation correction for ectopic kidneys, and their automatic void drawing algorithm too. And then we've got an example here of a really interesting paper from a pretty unknown physicist, actually. This is Jamie Wright from Glasgow. Nobody's heard of him, but they use an artificial neural network is developed to classify planar DMSA on a 6-point scale from definitely normal to definitely abnormal. And it performed better than a consensus human operator, and is suggested as a useful QC or classification tool for visitor reporting. So this is really exciting. Let's have a look at this. So I have a little insight here into how I review these papers and what I'm looking for. So I've got this, a really nice image here. The first 6 eigen kidneys. Didn't know that was a word, but they look really nice. We've got a nice diagram here of the artificial neural network. A really terrifying looking equation, and this very impressive ROC curve. So we've got the ROC curve here. In the dashed line is the consensus human operator, and in the solid line is the artificial neural network. So you can see it performs almost perfectly. This is the highlight from this paper was this sentence: we do not envisage the replacement of clinicians by automatic tools in the near to medium term. This was written back in 2014, so it would be good to catch up with the authors on that point. So after I've got all the papers that are relevant, we saw them. So Hermes is making this library. We use Mendeley to store all these papers that I find, and whether or not they involve Hermes software or not. So we've got Jamie's paper is here, but obviously it's not a Hermes paper. It's just relevant to our software. So we can tag these for post-market surveillance purposes, or if it is a Hermes paper, then I'll tag it with our software name. And if we were to include these new calculations in the application, we'd be able to reference be able to check the paper exactly for what the calculation is, and then reference it in the manual of the hybrid viewer application too.
Just so you know, Helen, there's 2 minutes.
All right, thank you.
Right.
How are we doing? Okay, just a few more highlights and notable publications. So these were a couple of highlights that I found for papers that didn't use Hermes. So colonic transit, these authors suggested fusing the nuclear medicine statics with coronal slices from MR to give a clearer anatomical definition of the tracer transit through the colon. And it's a really nice idea. Like Hermes can already do planar fusion, so I think it would be quite straightforward to implement. And I don't know if anyone's tried to do the colonic region of interest drawing, but it's really hard. So I think an MR would be really useful in that context. So I liked that one. It was quite nice. And then a really interesting gastric emptying publication here as well. They describe quite a detailed analysis of the dynamic stomach acquisition that they do. So they describe splitting in half the stomach, so proximal and distal halves. And they do Fourier analysis on the antrum contractions. Wow, this has gone way beyond what we do currently in gastric emptying. And they say that this helps diagnose gastric motility abnormalities. It's interesting stuff. A few examples with Hermes software. So a couple of these are the liver remnant applications. This is what Gemma was just speaking about before. These are from that Amsterdam group. So we have this paper, first of all, where they describe the technique completely and they reference the Hermes software, and they have screenshots from the Hermes software as well. So that's a really nice publication for us. It shows that our software is relevant and effective clinically. They also, another publication from that same group, is a clinical study into the effects of chocolate milk administration. So that's mentioned mainly because of the chocolate milk thing. But yeah, this is just the application being used effectively in a clinical context. So it's not like a study about how the application works. It's a study about just saying we use the result from it and in this clinical way. We've also got here referenced a really nice paper from the Glasgow group that Sarah already spoke about this morning as well. So in summary, this process took a really long time for me to do all of this. We need a lot of resources. Though I found no issues with the Hermes hybrid nuclear medicine processing software or any of the applied calculation methods. I also found no evidence of other CE marked processing software that had any superior or more advanced methods than Hermes. So all the suggestions that I found for new calculations were from in-house software created for a research project. So yeah, I'm pretty convinced from this that Hermes is up to date and doing well in nuclear medicine processing. And just to end, I did come across quite a few bizarre snippets from the history of nuclear medicine while I was doing this. This was a description of the way that gastric emptying was first done back in the 1960s, where in order to label a meal, a chicken's wing would be injected with technetium, the chicken then butchered, and the liver fed to the patient. Which is extraordinary. Thankfully, better methods evolved. So there we go. Okay, that's the end. Are there any questions?
That's great, Helena. Thanks very much for a great talk. There's a lot of work gone in there, and it's really good to see that that any of the things you're picking up on out in the field are being considered by the product team to get those implemented. There was one, actually, yes, there's one question here from Sarah Williams. She says it's not just a question, but I use the following resource to find papers on reviewing literature, and it's a great tool. And she provides there in the chat window a link. So thanks very much, Sarah. There, that will be very helpful. It's brilliant. So as there aren't any further questions with that, I suggest that we move on to our next speaker, who is David Hall from the University Hospitals Bristol and Weston NHS Foundation Trust. Hi, David. David will be telling us about his experiences on opening the box on Hermes, lung SPECT VQ, and lung lobar quantification. So thank you, David, for attending, and I shall pass over to you.
Yeah, hang on a second. I'm still, I haven't quite made you presenter yet, but it's coming. Here we go. There we are.
Right, so I can show my screen.
Yes, I think you should be able to share now. Yes, perfect.
Can you see my presentation? Ah, yes, I can see it in the top corner. Fabulous.
It's not maximized yet, but
I can do that.
There it is. Perfect.
Right. Okay. Well, this hopefully be a bit of light relief compared with some of the previous ones. This is more of a, if you like, a work in progress presentation. So Steve slightly oversold me on this. Actually, I'm just doing SPECT, not SPECT CT, and just the basic SPECT CT. We do SPECT lung scans for pulmonary embolism and also for COPD, but the COPD service has rather dwindled at the moment due to COVID having hit the elective surgery. Okay, so for pulmonary embolism, we do perfusion only, give 100 megabecquerels MAA. About half of these patients are pregnant, so they get a half dose, 50 megabecquerels. Occasional others at hypertension zone get a lower dose. We do use Krypton as well, but not routinely. Very, very rarely for this group of patients because they tend to be obviously quite young. So the existing protocol, we're scanning on a Siemens SIEMB or Intivo, basically the same camera. With SPECT, we're taking about 8 minutes to do a SPECT scan, so 8 seconds an angle, 64 projections per head, continuous rotation, and reconstructing on the Symbia. Also then doing planars, doing full ante and post and posterior obliques. Now the radiologist then wants anterior obliques as well, and it's already quite a long scan. So we thought, well, could Hermes help? So one of the reasons we got Hermes was to do the reprojection, but for some reason hadn't got around to doing that. So Hermes offers reprojection from SPECT to produce planars. So first we tried an existing lung SPECT study and ran it through the hybrid recon lung, and it didn't work. So we contacted Hermes. And what they said was you need a scatter window or CT required for reprojection, which creates a body outline for attenuation. So we put in some of the VQ SPECT CTs and found that eventually did work if we fiddled with the settings. So we thought, right, so we've moved the lungs on to doing studies with the scatter window, but for the moment carrying on with the planars for comparison. So first patient will show one of the full dose patients. And so one of the settings you need to apply is this have to apply scatter correction, and also collimator correction is what was recommended by Hermes. And it produces these artificial attenuation map images, which obviously are a reasonably good approximation to the body outline, if not perfect. So clever stuff. And from that, we go on to get some reprojection images. Now, these are actually looking pretty good, pretty nice. However, we had a look at these, and one of the issues was that there seemed to be some sort of horizontal stripes in the images, which we weren't that keen on. So I'll go and say what we did about that. There's the axials. So the stripiness in the images, this is something which had been mentioned at a meeting a few years ago. Someone had commented about collimator correction could cause problems with lung scans. So we decided to try that with that switched off, and so switch the collimator correction off, and the reprojection images just improved massively when you do that. So someone who knows more about maths could probably explain why that is, but certainly the collimator correction doesn't seem to be appropriate for these lung images. I think you wouldn't really see that so much on the axials, which is how we tend to look at the SPECT images. So I think they do look a bit nicer if you compare them head to head. But anyway, okay. So how does this work for a lower dose? Does this still work with the 50 megabecquerel study? And just jumping ahead to the few stages, the reprojection images look like this. Now they're a bit grainier than before, but they're pretty nice. You know, they are pretty nice. So let's compare those with the original planars. So the original planars from the Siemens are on the right, and the Hermes images are on the left. Now, one immediate difference you see is that the original planars were done with a 256 by 256 matrix, so they're slightly grainier, if you like. But the reprojection images look pretty good. And looking a little bit closer at a couple of them, at the right laterals and the RPO, you can see that there's basically the same level of clinical information in the images, but they're not identical. So the reporters will need to get used to them, and we are going to go and talk to the radiologists and say, basically, we don't have time to do all these planars. You know, get used to it. But you know, so we've looked through a number of these now. So on the positive side, the reprojection images actually seem to reflect SPECT better from some images we were looking at yesterday, and may actually have some more information than the planars. Because obviously the reprojection images are based on an 8-minute scan, whereas the planars are based on a 2 or 3 minute scan. Obviously, it'll save a lot of time. The reprojection images can have some sort of artifact on them in some cases, and we think that's it. Particularly, we've seen that in the RPO image. And we think that's from the arm, and people have got big arms, and it's outside the sort of field of view of the camera or whatever. That we're getting some sort of issue with that, but doesn't look segmental, so it shouldn't be a problem. Okay, and then there's the planar. Now, I think the axials. Now, clearly the axials are a bit noisier, but I think that's unavoidable with this level of scan. But they're still diagnostic. Okay, so to summarise there, so the Hermes hybrid SPECT for lungs is straightforward to get pseudoplanars out. The scatter window is required to define body outline, not for scatter correction. I mean, this is one of the differences which between the Siemens system, where you need scatter windows for things, where Hermes don't like scatter windows, and it stops their system. So now we've had to add scatter windows back in again, having taken them out. Collimator correction is best avoided with introduces a horizontal stripe artifact. And I did try fiddling with various settings on that, but I couldn't seem to see anything. But it does seem to improve it a lot, just not doing that. So the reprojection images are decent. Fiddling around with different numbers of iterations, subsets, final smoothing, that sort of thing, really make the basic settings are okay. It didn't seem to make much development. I think it was 5 iterations and 16 subsets. OSEM works best. There's various other options there, but they're for other uses, I think, where you've got SPECT CT. So we're going to consider increasing the SPECT time to say 10 or 12 minutes for the lower administered activity if we're not doing the planars. And we're doing a clinical comparison optimization underway, but I think we're feeling fairly happy now that this is the way forward. And then if there's any more optimization to do, we'll do that just based on doing the SPECT and the reprojection. Right, thank you. How do I get out of that now?
Thank you very much,
Thanks
David.
very much, David. Oh.
Right, that was short and sweet.
Yeah, it was really interesting. It was
let everyone in touch.
Your clinical sort of journey there. Yeah, so just for absolute clarity on the scatter correction issue, you're right that normally Hermes rejects the idea of scatter windows because we think that our Monte Carlo method of scatter correction is better than the energy window subtraction based scatter methods that lots of other reconstructions
Just
use.
one question on that. With the COPD VQ SPECT CT, we've been using the scatter windows partly to allow for a down scatter between the krypton and the technetium. Right. Now, it's not really based on science. That's just based on intuition that it's doing a triple energy window correction on the technetium. Now, Hermes doesn't really seem to like dual isotope imaging. I mean, it doesn't have a dual isotope gastric emptying thing either.
We do have several dual isotope reconstruction options, though. And in fact, krypton and technetium is there for lung imaging if you want to do simultaneous.
But will it do cross correction between the
two? It will do in the next version. Yes, in the version that's going to be soon, it will be doing that.
Right. Okay. Well, that's nice to know. That's nice to know. We'll look at
so just the way that the scatter correction is being used in this particular case is we make an artificial mu map with it. So basically, we compare the emission window with the scatter window and make a kind of crude 2-level mu map. So that's what you were showing with that kind of sort of hazy body outline. So that's how, because in order to get an accurate reprojection, you have to have an estimate of the attenuation of those photons going through and how they would hit a detector at various angles. So that the reprojection that Hermes does there is not just a summation of the projections around that angle, but it's like a proper attenuation corrected reprojection.
I mean, one of the things we did try was fiddling with that to see whether we could make the acquired planars and the projected planars more similar, and they are still different. So I think there is more information actually in the reprojected planars than there is,
I think that is
an
interesting problem, that isn't it? Because I mean, it's in a way it's not surprising because you're doing it from a SPECT, so the SPECT contains more information, and then when you reproject it, you're seeing more information there than you would normally have seen acquired. So does that mean the images are better, or is it worse?
If the attenuation correction is working correctly, it probably shouldn't. You probably shouldn't see more information. So I'm slightly confused about why that would be. But anyway,
you could probably put more of a, maybe more of a smooth. I don't know. That would make it even further away from your quite noisy acquired planars. But yeah, there was a paper done by the Royal Free a few years ago where they did exactly this. This was work that compared acquired planars to the reprojected ones, and they came out with the same conclusions as you, that they're not quite the same, but clinically they give the same information. Come out as the same thing in the end. Just a quick question on, you said that you sometimes do krypton. Is it too expensive for you to use routinely?
Yeah, we can't get krypton regularly. So I mean, there's an option there for them to get krypton for the next day, probably, or the day after.
Okay.
But that never happens. So I think the patients now where it's recommended to use MAA are generally the younger patients Now,
Mm-hmm.
there are some patients where you might just go straight to VQ SPECT CT in an ideal world.
Yes. Mm.
So say there was a patient who was allergic to contrast.
Right.
We have done one or two like that, but mostly the VQ SPECT CT was for COPD.
Right. Okay.
But those patients just haven't been wanting to come in during COVID, quite apart from elective surgery being cancelled. So that service is declined.
Okay, I'm just going to see if we'd have any questions.
There's a couple in the chat area, Helena.
Yeah.
There are a couple in the chat. I don't know if that's really relevant to. I'm just looking at. Yeah, I don't reckon. So there's 2 questions from Gemma, which are more technical Hermes questions. I'll take those externally if that's okay. Oh, what have we got here? I think there was a question from the previous talk, from my talk. Hang on a second. Are you able to see this question, Steve?
Yes, from Richard Peace. Yes.
Yeah, I'm just trying to pop out the question window because it's really small.
I can read it out if you like.
Yes, Richard Peace. Okay, great. Has Hermes, or our old name, Nuclear Diagnostics, ever been inspected either proactively or reactively against the MDR? I don't know. Do you know, Steve?
Well, we're regularly audited and inspected for our MDD CE compliance, and when MDR becomes effective, clearly that will be the case there as a routine measure. From the UK point of view, we are currently registering our software with the MHRA, which we need to do before the 1st of September. And that will be a fairly straightforward process because it'll really just carry over the current requirements, or the requirements that were in place on the 1st of January, they'll be in place under the MHRA. But when the MDR comes in, especially for mainland Europe, clearly a lot of our business is there as well, we will be being inspected against that once it's in place. Yes.